So my name is Karen MANTYKA. I'm a social worker with the Saskatchewan Bleeding Disorder Program. I'd like to introduce our panel here. So I'm going to go in order of who's sitting next to me. I'm going to start with Tony TAVARES. He is the star of the show. He's a Manitoba chapter past president, has served on the Manitoba Board of Directors for 44 years. Tony's a member of the Manitoba Healthy Aging Committee, has organized men's retreats, and is the co-chair of the Chapter Grey Cup Pool Committee. Tony has been a significant contributor to the CHS National with his work on the Youth Committee and the HIV/HCV Task Force. Tony was instrumental in achieving indexation for those members receiving the Multi-Provincial Territorial Assistance Program. Next to him is Dr. KELSEY UMINSKI. She's a hematologist and a clinician investigator at the Southern Alberta Rare Blood and Bleeding Disorders Program at the University of Calgary. She's actively involved in research and quality improvement initiatives, focusing on optimizing care for individuals with hemophilia and other rare bleeding disorders. Dr. UMINSKI has a particular interest in the intersection of aging and hemophilia, including the management of comorbidities and thrombic risk. Her work in this area has been recognized through multiple research grants awarded by the Canadian Hemophilia Society. Next to her is one of my favorite people, Nancy Hodgson. So Nancy has been a clinical nurse coordinator and research nurse with the Saskatchewan Bleeding Disorders Program for the past 17 years. I thought you said 16. 17, updated. 17 years. She has held several leadership roles on the CANAC executive, including president-elect, president, and past president. Currently, Nancy serves on the various committees for the CHS, the AHCDC, and the CAN-HC. In her role as a research nurse, she's involved in numerous interventional clinical trials and global studies across multiple specialties, including hematology, stem cell transplantation, gastroenterology, and interstitial lung disease. She's also the co-MC for today's Rendez-vous. And finally, last but not least, is Steve Anthony. He completed his Master's of Physical Therapy in 2007 at the University of Toronto. After pursuing outpatient practice in the GTA area, he made his way west in 2011, landing in an inpatient therapist position at Foothills Medical Center in Calgary. In 2012, he was asked to assume the role of primary physical therapist in the Southern Alberta Rare Blood and Bleeding Disorder Program, and benefited from the invaluable mentorship under its then clinical director, Dr. Manchu Poon, as well as then nursing colleague, Dr. Julia Hughes-Gerard, who we're going to see in a little bit. It was in Winnipeg, Manitoba, an annual hemophilia meeting over a decade ago when Stephen officially became the member of the Canadian Physiotherapists in Hemophilia Care. Welcome.
And it's a pleasure for me to introduce Miss Karen MANTYKA, is a radiant social worker at the Saskatchewan Bleeding Disorder Program in Saskatchewan. She has been working in this field for the past 13 years, both as a frontline for the mental health and addictions worker, and later on focusing on her work towards people who experience chronic and complex health conditions. Karen has a background in harm reduction and trauma-informed care, and is passionate about empowering individuals and family to navigate and overcome their challenge they face. I wish the panelists an excellent discussion.
Well, it's so nice to see everyone here, and although I'm working in Calgary, I am, like Julia Brooks, a native Winnipegger, so it's nice to be back home. And firstly, I'll say just the organization of today's session. We're really lucky to have Tony here with us, who has agreed for us to ask him a number of questions to really facilitate a discussion about his lived experience, thinking about how his hemophilia care and experiences has changed over his lifespan. And so each of us on the panel, from Nancy, Karen, and Steve, and myself, we're going to come from a different angle with a set of questions. And hopefully the flow and transitions are going to be okay. And so maybe, Tony, the first question I can ask you, just before getting into some of the aging-related comorbidities in hemophilia, is maybe you can just share with us and the audience, a little bit about yourself in terms of your type of hemophilia, your treatment, how your health has changed from your standpoint as you've gotten older.
Well, is this on? Yeah, okay. I'm a severe hemophilia, so I've taken basically all the treatments that were available through my lifespan, from cryoprecipitate to right now to Hemlibra. So everything in between, I've taken it. It's being a severe hemophiliac. You know, you were kind of grounded by your parents to do things that you weren't supposed to do and so forth. But that never stopped me. I was just like John. I've went through treatments that were great or good and got worse, and then to now where I'm taking the Hemlibra, which is it's been life-changing. And during one of my treatments, which is Cavaltri, I was taking 2,000 units of treatment, but my half-life was only like 5.5 to 6 hours. So I had to treat every other day as a prophylaxis and still have breakthrough bleeds during those treatments. So when Hemlibra came in, it was just like a cure for me anyway. And I think I've maybe taken Cavaltri maybe once in a whole year. So, yeah.
So it's just thinking about the previous panel that took place. I mean, a lot of the younger patients may not have had the same experience with the breadth of treatments that you've had to date. Do you mind, Tony, also sharing, I know that you shared with us that some other health issues have kind of come along as you've aged as well.
Yep.
And thinking about how that may tie into some of our discussions about aging with bleeding disorders, do you mind kind of sharing, some information about other health issues that have come along with your hemophilia?
Yeah, so during my lifespan, through my treatments and aging, I went through the Hep C and the HIV years, and got infected as well, and I cleared my Hep C, and my HIV has been under control. So I've never had any symptoms whatsoever in my lifespan. But as I got older, I ended up developing high blood pressure. And that's one of the concerns that, that I see coming up. I've had a friend of mine who actually went through a bypass, and he was hemophiliac. So our team was great, in collaborating with the cardiologists and stuff like that. So that's one of my concerns, what's going to happen to me, because our hemophilia treatment care center has changed. We have 2 brand new nurses and wonderful nurses. And as I get older, I'm going to be seeing other specialists, and one of the major concerns is trying to get involved, trying to get the HTC and the other specialists involved and come up with some sort of a plan. So.
And Tony, you mentioned that you've known another patient who had undergone cardiac pulmonary bypass procedures. So we are certainly seeing patients, thankfully that they're not passing away due to bleeding complications that are leading longer lifespans. And now we're seeing more patients maybe develop heart conditions that we would have thought that patients by nature of having a bleeding disorder would have been protected against. And how aware do you think the bleeding disorder patient population is in terms of understanding their risk for cardiovascular disease down the road?
I don't think they're quite aware, especially the younger generation kind of thing. But the older generation, I can see them starting to, ask questions. But ordinary hemophiliacs right now are just living a normal life. And who knows when, if they do develop hypertension or develop heart disease and start, getting some effects by it. So I don't think they're quite aware.
And your own personal knowledge, Tony, it sounds like you've definitely had knowledge of other patients being affected. How much do you think your hemophilia treatment center has been involved in making sure that you're well counseled on risks of developing heart conditions, and with that potentially the need for a blood thinner down the road?
Well, I don't know if the hemophilia treatment care team is aware. Maybe they are aware, but to me, with them, if you start developing like a heart attack or whatever, and God forbid if I'm the first one in Manitoba to do that and be like the guinea pig of it, but I think by taking blood thinners, there's going to be quite a balance there. You take blood thinners and you start getting bleeds, and then you have to go back into the Caval tree or the product. So that's a concerning for me. It makes me think like I'm taking a step back instead of a step forward.
Yeah.
So, yeah.
Yeah, I think you bring up a really good number of great points here, Tony. I think, I think about patients that we're seeing in the clinic. A lot of them have, non-steroidal anti-inflammatories, things like Advil, Aleve, listed on their chart to avoid because of recognition of the bleeding risk potentially associated with those agents. And then, your entire life is focused on avoidance of bleed, but then you develop another bleeding condition where maybe one of the treatments being proposed hand in hand with other things could be something that could further increase your bleeding risk. Thinking about how hemophilia treatment centers play a role in helping patients prepare for these conversations. I know we touched on this a little bit, Tony, but thinking about, a little bit more upstream, knowing that there are things we can try to do to modify our risks of later heart disease and that in terms of physical activity, dietary intake, control of health conditions like high blood pressure, which we know disproportionately affects patients with hemophilia than the general population, controlling hepatitis C, HIV. How do you think that how well are HTCs currently doing to be more proactive and encourage cardiovascular risk reduction?
I don't think it's there.
Yeah.
It's not there. I basically, when I got diagnosed with hypertension, I got diagnosed with internal medicine, and then they're the ones that diagnosed me with high blood pressure. So they came up with a plan where I went into medication where it wouldn't affect my other treatments. So that's the balance is right there. But I've gone to clinic and there's never been any communication with the hypertension or situations that could arise.
And I think this is probably some component that the HTCs were, this is probably going to be a bit of a shift in our care, recognizing that this is new territory for a lot of us here. That I thought I'd maybe direct the question to the panel, maybe Nancy, Karen, and Steve, from maybe each of your respective professional standpoints and personal opinions and experience. What role do you think the HTC holds in terms of trying to mitigate and support patients in reducing their cardiovascular risk, and also in controlling any cardiovascular disease that may develop?
So, of course, we need to take, you can hear me, yeah? A more personalized approach and kind of reevaluate your medications that you're on that have a long-term impact, and make sure that they're safe and don't increase your bleeding risk. I think we also need to kind of educate on adapting the heart-healthy lifestyle, exercise, better diets, weight management, smoking cessation, and always considering bleeding precautions.
Right.
Thank you, Phoebe.
We can do a better job on that.
Yeah, thank you so much, Nancy. Maybe Karen, from your standpoint?
Sure. I think a big part of it is listening, figuring out what's, the personalized approach, as Nancy was saying, but figuring out what's working and not working in the person's lifestyle. I think a lot of times With the medical model, we have this idea of, good, better, best. And so, of course, we always want to push the best treatments, the best exercise, the best diet. But realistically here, who smokes and drinks and eats fatty meats? And we all make decisions every day that aren't necessarily the best for us. So I think it's important to have those conversations with the patients about what's working and what's not working. And even if it's not the best approach, well, what would be good or better to fit in that person's lifestyle?
Yeah, from a physiotherapy perspective, I just want to echo the same sentiments as my colleagues on the panel here. I'm glad we're at a point where we can have these conversations where our patients or our clients are living longer, but unfortunately they're developing these other conditions. And so I think from a physical perspective, an ounce of prevention is worth a pound of cure, and just, physically what they're capable of, and that includes a physical activity regimen just based on where our clients are at. And that's not only aerobic conditioning, strengthening, but also includes flexibility as well as balance training to make it all-encompassing for the patient to reduce that cardiovascular risk.
Mm-hmm. Yeah, thank you so much, Stephen. One thing that just made me think of is, contrasting in the last panel that we had, we have sort of someone that's a bit younger contrasting with one of our patients who's older. A lot of the counseling that we've provided to different patient cohorts has obviously changed hand in hand with the therapeutic options that we've had. So I do find often patients who may be kind of 50 and older, we're trying to break down some of the learned barriers where previously activities were thought to be restrictive or we were discouraged. So having to change that mental model takes some time. So I think that's all the questions I have. I'll maybe hand it over to Nancy then.
Do you want me to, should I just sit here or shall we come up or?
Oh, whatever you prefer.
Huh?
Okay, I'll just keep standing.
Yeah, you're doing an excellent job. So Tony, you had mentioned that Hemlibra came at it was life-changing for you.
Yes.
And I know when we had our kind of pre-session for this session, that you were saying that peripheral IV access was becoming a bit of an issue. What challenges, if any, do you foresee in continuing to manage your factor treatments independently as you continue to age? And are there any specific aspects of your current regimen that you might see becoming more difficult?
Well, I guess as I get older, it's inevitable that I might get a little bit shaky and on the hands, and a little bit in there, start losing your eyesight or whatever. So that's going to be a challenge. If I was put in a care home, the biggest challenge would be who's going to be at the care home and learn how to do your product, who's going to administer it, and that's just the daytime, because the nighttime you have less staff, right? Because I went through this with my mom in the care home, but you have a night staff which is shortened by the amount of people that work there at night. Is there somebody that's going to be there at nighttime that's going to be able to do your treatment, right? So these are concerns, right? If I did get a trauma at a care home, who's gonna take me to the emergency in the middle of the night? So those are big concerns, and I think, I don't know if you want to ask me about what do I see that would improve. That would be communication between the hemophilia treatment center with the home or the facility that I'm at. So I think there would have to be a lot of education about that, and yeah.
And probably pre-planning for those unanticipated events.
For sure.
Yeah.
Yeah.
Now, you mentioned about going to emergency room.
Mm-hmm.
How would you feel about sharing your experiences in the emergency room?
Well,
Yeah.
it's, you know, it's
challenges, yeah.
It's very challenging. I mean, I'll give you one incident. I went into emergency in my early 20s, and the staff, the nurses didn't know how to treat a hemophilia. And I would actually tell them where to go get the treatment. So they didn't even know that. And then while I was in the emergency, when the treatment came up, I was the one that was actually doing my own treatment, mixing it and treating it. Now I know there's been a lot of improvements with the one card, the treatment card, whatever.
Factor First?
Yeah, Factor First, sorry. I've never used it, so but anyway.
What?
Yeah, we didn't.
Finger wagging, no finger wagging.
We didn't have it back in those days.
Oh, okay.
We didn't have it back in those days. And I do carry mine in my wallet since my nurses got after me.
You get positive points back
Yeah,
now.
okay, I got that. But it was challenging, right? And so for me, right now, if I did need an emergency, okay, if it was this was late at night, let's say, I banged my arm, I needed to go to the emergency. And I know I'm gonna be waiting at the emergency because I'm not first priority. So I'm gonna sit there for about 10, 13 hours and waiting for a doctor to see me. I would advise people just to take a treatment, stay home, wait until your HTC opens, and then call them and get in there. You're gonna see people a lot faster than you would during an emergency. That's my personal opinion. So, yeah.
Thank you for sharing that.
Thanks.
And I'm sure, Tony, that some of the your experiences you expressed, we certainly know. I know Dr. Khalife, Dr. Jackson, and a number of us have looked at our own HTCs and processes across the country. That's certainly what you've experienced in Manitoba is by no means an outlier compared to other provinces in that way. And just to your point about kind of getting in to see, a member of the HTC the following day, I think there's a lot of variability in being able to provide that care to our patients. And I think it just speaks to the ongoing work we need to do and advocacy to make sure that we're providing fully comprehensive care for all of our patients. Maybe Karen?
Hi, Tony. I have to admit, we all had like 15 questions for you when we first started. I think you know that. We've tried to trim it down, so I will try to be succinct. But when I was thinking about aging with bleeding disorders, I was kind of thinking about the crossing of chronic illness, aging, and with that usually comes some chronic pain as well. And really the intersection there's the commonalities seem to be a sense of isolation, loneliness, maybe loss of community support. And that can be for a multitude of reasons. It could be because of hospital stays, the physically being isolated from your home and community. It could be because there's less people to maybe validate your experience and share it with you, and you share it with others. And it could be just, a lot of the community supports, when I'm thinking about the sort of the provincial chapters and the wonderful work that they do, are really focused at families and young people and new diagnoses and helping them through sort of, learning those sorts of things. So I think there's a sense of sort of disconnect even from sometimes the hemophilia groups and things like that. So I'm wondering what your experience has been with that, if you've had sort of that sense as well or had experiences with those.
So pain and...
Sort of that loss of community, isolation, loneliness, finding it hard to connect with other people who have similar experiences as you get older.
Well, in the early stages, we used to have a men's retreat, and we used to go to these men's retreats with all hemophiliacs who were basically dealing with the same situations and all that. So we had people to talk to, and we'd ask questions like, what do you do for this? And what do you do for that? And it was helpful. But we don't have that, anymore because most of those guys are gone. So now you're on your own kind of thing. when I had, before I had my hip replacement and knee replacement, I was going through a lot of pain, but 3 years before I even got, that done. So I was on morphine, and it was very painful. Even when you were on morphine, it was painful. But you isolate yourself from your family, your friends, everything. My wife, she wouldn't want to be around me. I was miserable to her, and I'm sorry for that, but it just so happens. And then my parents were the same way. I wouldn't want to deal with my parents, and I even came to a point where I might even have to go and check out a pain clinic or something. But it was a rough time in my life, and yeah, you do isolate yourself. Your mental health. You start asking questions like, why am I around, and why do I deserve this? Do I really deserve this? You know what I mean? But it was very hard. It was hard, So yeah, you do seclude yourself from everybody.
Mm-hmm. And that does make sense, and I want to thank you for being so open and vulnerable about that, specifically because there can be stigma around addictions, but when it comes to chronic pain, I'm a firm believer, even though I have not experienced something like that myself, I don't think any of us can judge unless we've been there ourselves and have had to go through that. And part of that is part of that mental load that you have to carry, right?
Yeah.
On a day-to-day. It's not just getting the blood work and getting the tests and getting the treatments, it's the pain that nobody understands, or the addictions that could happen as part of that when trying to manage the pain medically as well.
I was addicted to the morphine. Being on 3 years, I never thought I was addicted at all. Mm-hmm. But after I had my hip done, and they start pulling my morphine, and they did it cold turkey. Mm-hmm. Not good at all. Like I was sleeping on the couch, I couldn't stay awake. Cold sweats. Felt like you were crawling out of your skin. I have never lived like that before. Like it was bad. Mm-hmm. So now when I see somebody who's addicted, I understand. Mm-hmm. Mm-hmm. But it took me to have what happened to me, trying to understand what they were going through.
Yeah, that's a huge amount of empathy, and I can appreciate that. Speaking of the mental load, I'm just reminded of what Rick was talking about with the bike ride. Now I don't know where Rick is, and feeling that anger sort of about having to do this, and why when it's such a simple task. So I'm wondering if you can speak a little bit more about the mental load. There's a common idea now that of sort of disease management burnout, of the fatigue that comes with chronic conditions and chronic pain. Can you speak a little bit to your experience on the mental load and the day-to-day? And if I could add one more piece to that, is what has been helpful for you to manage that? And what would you maybe say to others?
Talk to someone. I've always had, with my hemophilia, I've always been open about my hemophilia. So being in pain and chronic pain, it helps to talk to someone. Talk to your wife, talk to your kids, talk to your nurse, your nurse, social worker. The pain that I've had with my knees and my ankles, Greg got a lot of calls. I'm in pain, like I need something. And he would actually, would talk to the nurse and come up with some solution. It was a burnout. It was a burnout. It was a burnout.
Thank you so much.
How are you doing over there, Tony?
I'm good.
Okay, we're grilling you. You're hanging in there, so we appreciate it. Awesome.
I wrote all these notes, but everything was just coming out of my head. So.
Well, it's almost like we had planned it, right? Tony, I think you alluded to it before, but you just want to be clear. Do you mind listing the joints that have been impacted by your hemophilia and briefly describe any treatments you've undergone to address those issues?
So my first trigger joint was my right knee, and at the age of 13, I had a synovectomy done on my right knee, a surgical synovectomy, and then at the age of 35, I ended up replacing that knee. So it was pretty young for a knee replacement. With that being said, when I had my surgical synovectomy, my knee replacement, I put a lot of strain on my left knee. So that triggered my left knee as my trigger joint. I think in my early 20s, I did a chemical synovectomy, where they shove a chemical ingredient into your knee joint and it eats away at your synovium and cleans it up a little bit. But with that, it actually accelerated my bone density. So I ended up getting that knee replaced. So my other joint was my left elbow, and so I've been treating for that. But with that being said, my left ankle and my left hip and right knee were going. They were just arthritic from all the bleeds. So I had my left knee done at 35. I had my right knee done at the age of 48, 49. I had my hip done, and my ankle done a couple years ago.
Okay. And so obviously pretty invasive procedures. What kind of prompted you to pursue that route?
Pain.
Pain?
Pain. I couldn't stand the pain.
Okay.
Ankle, my right ankle, the year before I had my ankle done, prior getting my ankle done, I was falling down a lot just because I would roll my foot.
Yeah.
So that's what made me do my left ankle.
No, and
right ankle, sorry.
And thank you for sharing that, Tony. As Tony alluded to, falls and the risk of falling is critical, especially as we age. The World Health Organization estimates that up to 35% of people over the age of 65 have at least one fall a year. And once you have one fall, you're more prone to falls. And, with every subsequent fall, your chances of falling again exponentially increases. And it's kind of intuitive that, falls risk, it does increase with age. You have decreased strength, limited agility, decreased response time, not to mention challenges with your vision. The medications that we prescribe or the interactions of those medications can affect falls risk. And also the challenges to mental acuity. But obviously having hemophilia poses more challenges to that. Because obviously there's degradation of the joint. And then with the degradation of the joints, especially the weight-bearing joints, there is definitely challenges with respect to that. So decreased flexibility, joint instability, decreased strength, atrophy of the muscles of those impacted joints, not to mention the chronic pain that you alluded to, Tony. All those increase the risk of falling. And so why is falling particularly concerning for those with hemophilia? Well, we know, as Tony mentioned, that you do have decreased bone mineral density, as we call osteoporosis. And we know patients with a bleeding disorder do have decreased bone mineral density, which makes them more prone to fractures when they fall. And not to mention, uncontrolled bleeding. And just with my other hat, other than hemophilia care, I work on the trauma ward in Calgary, and we get a lot of elderly patients with falls. And some of those patients do come in with fractures, but some of those patients do come in with traumatic brain injuries. And with someone who has a challenge with coagulation, that can decrease independence, decrease function, but it can also be quite catastrophic. So it's important to mitigate that risk for sure. Tony, I have one last question for you. So in your advancing years, do you mind just outlining some challenges you're having with completing just day-to-day activities?
Well, my life has actually improved over the years. And I'm not talking about, I'm talking about like, I do a lot more now than I did 10 years ago or 15 years ago. But it was the road to this point that was hard because all the surgeries and so forth. I used to climb a ladder, and now I try not to. I'm saying that because Greg's wrong. But, because my ankle doesn't, I don't got full flex in my ankle, so I try to stay away. I get people to do it, but now I can go cut the grass and not feel the pain in my joints. And but prior to that, walking. I mean, even today, because my left ankle, I have drop foot, and I have to get that ankle fused, but that's for another time. But I think my life has actually improved with all the surgeries, but at the time I was suffering before I got to this point. Helping the wife, vacuum the floor, wash the dishes, whatever. I do all that stuff now, but nothing really held me back at that prior to that either. So I just kept on doing what I did.
Yeah, so I think from your perspective, joint damage can make even the most simplest tasks a little bit more challenging.
Big time.
Yeah. So I think, okay, we're out of time. All right.
I'm sorry, Stephen. I was just saying that we are running out of time, and I just didn't want to go over. So I wanted to take this moment to thank our panel here, specifically Tony. Oh, sorry if you didn't hear me before this. Specifically, Tony, thank you so much for being so open over here. Dr. UMINSKI, you've done a wonderful job. Thank you so much for your insight. Nancy, great job. Stephen, thank you so much.
Thank you.
Are we doing questions?
My
name is Michel Long. I'm the National Program Manager at the CHS. I just want to use this opportunity, since we have a session on aging with a bleeding disorder. As you all know, people are living longer and healthier lives thanks to the progress in care and treatments over the last decades, which is fantastic. However, you've named a number of challenges that still exist. We're out of time now, but I was going to ask, what specifically are some of the areas that we need to delve into in terms of research? And the reason I'm asking this, and you can think about it, and people in the audience as well, the reason I'm asking this is because the CHS has a research program called the CHS Bayer Advanced Research Program, and it is focused on aging. And unfortunately, we haven't been receiving many applications. Last year, we received none. And it's really putting in jeopardy this funding for this research program. So if there's not much interest, it's very hard to justify to Bayer to keep funding this. So I just want people to consider the things we've heard today and to submit some proposals. Similarly, you talked about the mental health burden and so on. So we also have the Novo Nordisk Psychosocial Research Program, which could also consider applications in this area as well. So please do consider this. So I just want to put this plug in. I think it's very important. And earlier today, people were applauding when I think it was maybe Dr. Lil Crap was talking about we need to secure better research funding. Well, we have research funds, and unfortunately, they're not being used. So please do consider that. Thank you very much.
Just one more thing about, and I was going to mention this, but I didn't. I think it's important for us hemophilics who are getting older to approach our HTC treatment centers and approaching the doctors and seeing if we can get seen by cardiologists and social workers and so forth, and come up with a plan as we get older, because it's going to arise. So.
And I think, Tony, you hit on a point that I've been thinking in about just what came up from each of the different perspectives that we had is I think now that our patients are not coming in so frequently with bleeding events where our approach had been palliation of symptoms, treatment of bleeds, I think our focus of care needs to be more preventative, so preparing our patients for how to mitigate their cardiovascular risk down the road. For patients that are at risk or those who develop cardiac conditions, I think the composition of our hemophilia treatment center is also going to change, involving cardiologists, neurologists, maybe a geriatrician now too. So I think we need to be adaptable with these new and rising health-related issues.
For sure.
Awesome.